what would you like to leave people with today that they should be thinking about moving forward?
We have reached a point where 10 years ago, technology was the barrier. We have reached a point where technology is no longer the barrier. The next generation EHR is not about software. It is about restoring clinical cognition. And whatever we can do to restore clinical cognition, that'll be a successful EHR.
I agree. For 20 years, we've been trying to get people to use the technology. Now they're taking and running with it. And I think there's a real risk. We've thrown so much technology at people and they're using little pieces of it. We need to get them using it correctly. I think a lot of that training and support is going to be a big part of what we need to do in the near future.
Well, I'm hopeful. I'm listening to two CMIOs from big health systems, and I think you guys get it and you understand the landscape and what the opportunities are. And there really is opportunity. I really do feel like we're entering a next frontier of hopefully restoring joy in practice of medicine.
Welcome to Beyond the Blueprint. My name is Greg Malkery. I'm the Managing Director at Lighthouse Health Tech Advisors. Today, we're going to be talking about the next generation electronic health record. This is not a conversation about features or vendor roadmaps. It's a conversation about how the EHR works in practice. This episode is part of our collaboration with AMDIS, the Association of Medical Directors of Information Systems. Well, to help us unpack this, I'm joined by three leaders who are solving these challenges every day. We have Dr. Howard Landa, the Chief Medical Informatics Officer at Adventist Health. He's an expert at making complex data work for large medical networks. We have Dr. Evie Cunningham, the Chief Medical Officer at Cadence, and she's a specialist in designing workflows that optimize the patient visit. And we have Dr. Deepti Pandita, the Chief Medical Informatics Officer at UC Irvine Health, where she's a leader in using innovation to improve care at major medical centers. With that, why don't we go beyond the blueprint? Now, before we dive into today's discussion, I want to recognize our valued sponsors who've made Beyond the Blueprint possible, Simplify Medical. With their support, we're able to bring you insightful conversations around healthcare design and innovation. If you enjoyed today's show, I encourage you to subscribe so you never miss a future episode. We all want technology that helps physicians instead of slowing them down, but many clinicians that I've interviewed report that the EHR actually does the exact opposite. When a physician is forced to manage more than 100 inbox messages a day, the system is not supporting care. When every extra click or screen transition pulls attention away from the patient, the system is working against clinicians. The problem is not about physician resistance. It's about how these systems have been designed, governed, and rolled out. Those choices decide whether the technology reduces burden or quality adds more of it. And if we don't get the foundation right, no amount of AI or automation is going to fix that experience. So the next generation EHR must help physicians get real work done during the day, and it must give time back to physicians so they can focus on patient care. So we've talked about the big picture. Now let's look at where are we today. Deepti, I'd like to ask the first question of you. So let's start with the rules. If a health system lacks a solid data strategy, can they safely deploy AI, or are they just creating massive legal liability?
Well, the latter, because bad data will lead to bad AI. So let's start with that, because at the heart of it, I have this slogan I use, which is AI is math, not magic. It might feel magical, but at the heart of it, it's mathematics. And if mathematics is data, so if you have bad data and you don't have good data governance, you will not have a good AI output. So again, data governance is a prerequisite for good AI adoption. I mean, AI is not going to reduce any cognitive burden of the clinician unless the underlying data is clean. Data today from the EHRs is very noisy. It's duplicative. It does not even have contextual awareness most of the time. So governance needs to have alignment in terms of ownership, terminology, operational intent, and only then will that data be able to be used meaningfully to drive good AI outputs that truly help clinical workflows and not just what we have been using EHRs for so far, which is just care delivery for compensation and revenue cycle.
Does UC Irvine have a robust data governance strategy?
We do, and we have a robust AI governance strategy as well. And we combine the two because, again, we understand that without good data governance, you will not have good AI governance.
Thank you, Deepti.
And can I piggyback on that for a second?
Sure you
I
can.
think
Go right
in
ahead.
addition to the hygiene and the cleansing of the data to have it really structurally be meaningful for a clinical impact, you also have to have the clinical validation piece, which is another thing that I think a lot of health systems have the opportunity to leverage because they have so many clinicians like within their institutions. So in order to make that data meaningful, you need both the data governance and the clinical validation sort of muscle to be able to make sure that it's actionable at the point of care.
Howard, I know you got a lot of opinions on this topic because we just actually had a session last week on data governance. Howard, do you want to chime in here?
Yes, I'll agree with both. Deepti pointed out the noisy data. Well, I go one step farther. There's a lot of inconsistent data. Stuff that comes in from the lab, hopefully radiology reports, those things are fairly consistent, but you've got humans doing all this. When it comes to your problem list, all of your diagnoses, people honestly disagree. And sometimes they're just errors. And you find charts that have, left side versus right side that aren't correct. And how do we clean up that data? It only takes to Deepti's point, it takes a small amount of bad data to really throw AI off dramatically.
Excellent. Evie, I want to ask you a different question. Within clinics, and I think we had a conversation, you're actually a practicing OBGYN, I believe.
Yeah.
Where exactly does software break the bond between the physician and the patient during a visit?
The minute I step into the room and log into the computer. I mean, honestly, like I was just did I was talking to my buddy, Dave Newman from Stanford Health, and he's the CMO of virtual there. And he said that they just started using Ambient there. And he had a patient who told him that it had been the first time he had looked at him in 10 years. Like, I mean, that is, and I mean, here's my point of view because I'm an OBGYN, so I'm a specialist. So a lot of the patients that I see are new patients that are new to me. They're referred to me. They've had a problem. Maybe the problem has been worked up to some degree, or it's been treated, or they've been treated in multiple health systems. So I need to get into their chart. And when I'm talking to them, there's things that I need to look for in the chart while I'm having that conversation because I need to put the whole picture together. It doesn't come necessarily in this nicely packaged like synopsis of like everything you need to know, specialist, about what just happened about this condition.
Not yet.
So a lot of times this is buried in the chart or it's sitting in care everywhere because the patient is hopped amongst many different health systems in our market. And so like, what I would like to challenge all of the ambient care, agentic care vendors out there to think about is how do you create a keyboardless experience in the exam room, right? Because I think that the technology exists for us to be able to do that in the future, but like really it's broken the second you walk into the room and you have to log into the computer because you're not that patient encounter, that sacred encounter where you can really connect with the patient is broken by that keyboard and screen.
Howard, I think you guys are migrating toward Epic. Are you is this part of one of your central design theses as you're designing the system?
Well, absolutely. I mean, we've rolled out Ambient and Cerner where we are, and the responses we get, and I think this will resonate with everyone on the panel, it changes the way you feel about your practice of medicine. It brings the joy back into medicine because you can go back to communicating with the patient, working with them. That face-to-face interaction that we lost when someone is staring at a screen is back. So I think that's where we are. I think to Evie's point, all the rest of the data of the chart is the challenge. And I think we're getting to the point where the systems are intelligent enough to start bringing that together and presenting that to us even before we walk in the room. But as things evolve, now what happens? Something the patient tells you is net new, and there's a piece of data somewhere in the chart that you need. How do we communicate that to the provider in midstream? So I think there's still plenty of challenges, but just so much potential.
Deepti, what about at UC Irvine? How are you guys addressing this issue?
Yeah, so we just actually did a huge Epic implementation as well because we had disparate systems across our community networks and our own academic systems. So we are calling it Intelligence Ready EHR, which is basically that we enabled about 30 to 40 AI features from Epic and some external ones too, including, ambient documentation and all of that. All these systems are really good and will ultimately reduce the cognitive load of the clinician, but they are still not at a point of being an intelligent clinical partner to the provider. And that's where I think the space needs to move. They're all standalone solutions for a problem, but they don't have the full landscape end to end, like Evie was asking for. Is you walk into the patient room and it's just you and the patient. Everything else needs to be captured in a seamless manner so that you can just be present for your patient. And they're not there yet. They are solving one problem at a time, like an in-basket problem or a note documentation problem or a charge capture problem, but they are not looking at the entire ecosystem. And that's a gap still.
How much work? So Epic gives you certain foundational technologies. How much work is on the provider organization in terms of what they need to do to customize it to address the unique needs of the organization and also the different providers or specialists?
A lot. I'll give you the perfect example of, like Epic has a tool which can be used to respond to in-basket messages, which is, very well thought out, great. And you use the tool, and we implemented the tool. We were very early adopters. And take the example of a pain clinic where the patient is always inputting their pain at 10 out of 10. Of course, they're enrolled in a pain clinic. They are in pain. And the consistent response from the AI tool was recommending the patient to schedule an appointment. Well, that was not the right response because what they were seeking is in that spectrum of chronic pain, what they needed to do next. And providers are not, inherently prompt engineers. They could tweak the prompt to a certain extent, but they didn't know how to reframe the questions for the patients to actually get them to answer in a manner that would not lead down the path of needing an appointment. So those are the sort of gaps because you have to tailor these tools internally, and we had to create a prompt library internally to tailor it to each specialty in order for the tool to get more effective. And that's a lot of lift. Most systems have IT staff, but they don't have prompt engineers. Most clinicians are not inherently prompt engineers. So who does this work? It's a whole lot of extra work beyond what you do to run an EHR.
Now, this is an interesting point. I think I was talking to Howard offline a few weeks ago. We're talking about Epic Cosmos. How are technologies like Epic Cosmos, are they even ready for prime time? How are they changing clinical decisions during the patient exam? Or is this a work in progress and maybe it's 3 to 5 years out?
I think it's definitely still a work in progress, but I think it displays this great potential. Deepti was talking about the difference with AI within a specialty. I think the EHRs have done pretty good jobs of creating tools to do documentation and ordering within each specialty, but the AIs are still very generic. They're not really tuned to those specialties. I don't know if that's our role to do that or that's the vendor's role, but I think that's something that's going to evolve. What Cosmos gives you is a conglomeration of experience of millions of patient records that you can now leverage. How we actually make that effective, if I'm looking at spreadsheets of data while I'm talking to the patient, that isn't the way I want to have my encounter. I may go back and do that later, but can I summarize what's in Cosmos, what's in the patient's chart, and what we need to do based on where the patient's care process is going, and put that all together? I think that's the real challenge.
Yeah, and I'd piggyback on that like I haven't seen how Cosmos is helping me in my daily clinical practice or in when I'm actually seeing patients. It's not, to Howard's point, actionable yet. What I've seen that's interesting is where they sort of create these smart EHR UI wrappers. I know that that's eventually where the big EMR vendors are going, but it's basically like, how do you create a contextual view of what's going on with the patient that's specific to a condition, that's specific to the specialist or the type of clinician that is seeing the patient, and that's specific to the setting that they're in. Because a cardiologist that's seeing an inpatient for CHF exacerbation in the hospital, or a hospitalist seeing that patient in the hospital, is going to want a different point of view around what's happened with this patient and what's in their chart, versus when that patient gets referred to me 3 weeks later for workup of their postmenopausal bleeding that needed to get followed up after they got discharged. Like, it's very different. And like right now, it's just very generic in that you have to go mining and looking for things in order to create actionable intelligence around what's happening in the patient's chart.
And also the ability of being able to guide you through the care process based on best practices. I did hear about a technology called MedPearl that actually has been very useful at point of care. So what's going on as you look at Epic and you look at third-party products, how do they kind of come together? Are they at the same spot in terms of introducing technologies that can be brought together at point of care, or is it kind of the Wild West?
I'll let Deepti answer that.
It's a little bit of both. I'll tell you that the dependency on third parties has always been there, and that's because the EHR vendors have always lagged in terms of their R&D, and there's always an unmet need on the clinical side, and that's why the third party vendors have succeeded in filling that unmet need, whether it be around decision support tools or care coordination or whatever. I have seen some change there where now the EHR companies are moving a little bit faster because they have realized that they are, missing out on an opportunity here with having those unmet needs not met. But on the flip side, companies that have third-party vendors cannot do away with them because we have 5 and 10-year contracts, and these are not cheap. So we have not realized the benefits of what we have already implemented yet. And then we have to buy yet another, if the EHR company comes out with that. So it's a lot of push and pull in this tight financial market where you have to always balance the unmet need versus what you already own. And, app rationalization is part of what I do on a daily basis. And it's a hard one because you have to get ROI from what you already have before you think of moving on to the next one.
Well, you bring up a really good point, but what happens when we add on to our existing systems, which may be broken? The AI technology is moving incredibly rapidly. When do you know when to throw it out and start from scratch? Or what are the unintended consequences for adding new technologies on top of what's already exists?
It's a constant evaluation. I mean, as you said, we're in the middle of an implementation. We have written contracts with hundreds of other vendors to support what the EHR doesn't do. And to Deepti's point, they all want long-term contracts and we all want no-term contracts. So we compromise in the middle with a couple of years, but I think it's going to be a constant reevaluation. I've never seen anything move as fast as AI to change the entire environment, really, to provide that disruption. So I think we're all going to need to, in a much more proactive and directed way, start looking regularly at all the technology we have and saying, is it providing value? How long do we keep it? What do we replace it with? Because the EHR vendors are also out there trying to replace those. And they cannot pivot as fast as a small company, but those small companies fail at a pretty rapid rate. So trying to figure out what the right thing to do is today may not be the same answer a year from now.
Percent. Hey, Deepti, many physicians today are starting to use their own AI tools because they feel the official systems are moving too slowly. I actually live in Stanford Mafia country here, and they're very blunt with me on how they're using the tools at point of care. What are your thoughts on this topic? How do you handle the shadow AI without creating more rules that doctors will ultimately ignore?
My real answer is I pretend it doesn't exist, but but I know also for a fact it exists. So, when I think of shadow AI and when it comes to my notice, I actually feel bad about it because it's not a compliance failure. It's actually a failure to not having met a need. Because that's really why people will leverage shadow AI. And, clinicians will adopt any external AI tool when the enterprise system is moving too slowly, or we are getting things wrong, or we are not accepting the reality of boots on ground situations. And I think how I think about it is guiding them, educating them to a governed pathway for safe experimentation. That's the stance I take. Is I never say no, but I say let's look at the pitfalls of how you are doing this, using this tool. You might be exposing PHI. It might come back to haunt you because you're liable for it then. So I always go, okay, before you go all top-down regulation, enable, but make sure that there's transparency in that enablement through good governance frameworks, and then make sure that you're transparent in that so that you're educating your end users as to why you have that governance framework. Most people don't understand, the pitfalls of a tool that is coming out as I am HIPAA compliant. That does not mean that you have a data user compliance. And that does not mean that, you can actually put PHI in there. And that's all education.
Deepti, is there a framework that's been published out? Are you regularly communicating with docs as AI is moving so rapidly on what they could do, they could not do, or, where the gray areas? Is that well communicated at this point?
Well, what we do at UCI is we do both. So we do have some communications coming out about responsible use and approved use. But on the other hand, what we have done in informatics is take the education stand. So we have webinars internally for our, all of our clinical users, including nursing, pharmacy, our faculty providers, all of them. And in order to guide them as to what it means to have AI governance frameworks and why we need them.
I have a question for you related to this topic. If AI causes a mistake, it hurts the patient, who gets blamed? The doctor who used the tool or the leader who decided to buy it?
Well, it kind of depends on how the AI, I would say, is actually being used. But right now, from a regulatory perspective, right now, like for most AI tools, like the clinician is responsible. And I don't really see that landscape changing very much due to the fact that I know there was like the big announcement that came out that Doctronic is going to do med refills in the state of Utah. But, that's the state of Utah. Every single state has their department of licensing. Every hospital has a credentialing. Every payer has a credentialing. Like if AI was going to be responsible for what happened. So for example, if CMS releases CPT codes that then allow the AI company to bill, you still have to go through all of these gradations of licensing and credentialing to figure out who's like responsible ultimately. Are AI companies going to hold malpractice insurance? Like, I don't know. I mean, so it's going to be kind of interesting to see how the landscape sort of evolves. But we have all of these large, I would say, over bloated administrative processes in place across all of these institutions and payers and states that I'm licensed in all 50 states, so I've had to go through this process, and it's like not a scalable process in the way the system is set up right now for us to have like a credentialing for an AI. So it's still going to come back to the humans who have gone through that process is my prediction for at least a while.
Sounds like a very complex decision-making process.
Yeah, our AI governance, we were very specific in saying that all AI will go through a clinician before it gets used, but starting to look at things that are coming out in the industry where maybe they're safe enough to actually allow it to work autonomously. We're trying to figure out exactly where's that divide. Right now, everything goes through a clinician's eyes. But eventually, if it's something less risky, I think we may get there. But to your point, the AI vendors aren't going to be responsible. They can sue them, and that's there. At the end of the day, clinicians are still your caregivers, and we're still the ones making those decisions today.
Howard, as you guys are transitioning to Epic right now, can you name one specific job that we should be giving to AI in the next 6 months? Generating documentation, handling scheduling, ordering medications. What's the highest priorities now for leveraging AI within the EHR?
I think the highest priorities to me are providing it to the patient. And again, to your point of making appointments, identifying referrals, knowing where to go for the right thing. And we have always, one of the biggest failures in medicine is around behavioral modification. We can't change your genetics. We can't change, can't really impact your social determinants of health, but behavior is where it's all about. And if we can give patients tools where AI can interact with them, taking their preferences, their ideas, all those kind of things into account, then that's going to help us care for them. I think that's where their big opportunity is.
No, that's a really great point, because I've actually addressed this issue recently. I had a really violent cough for about a month. I got referred to an ENT at Stanford. It took me literally 3 weeks to get in. So I was using ChatGPT to diagnose myself and come up with my treatment plan. So I go to see this young doctor at Stanford. This was unbelievable. And he was really nice, right? And he listened to me. Nope. Everything I said was wrong. And he was really nice about it, but I must have wasted a lot of his time in the process. Would I do it again? Absolutely. But it was an interesting experiment. But for me, I'm glad I had a tool to ask. It gave me some level of context, even though it was ultimately wrong. So for you, with the rise of AI agents and digital assistants, how is this changing the way you guys are approaching patient engagement?
Yeah, I mean, I think like to your point, there's just a study that just came out there was a Gallup poll that just came out. 16% of patients are using LLMs and AI, ChatGPT, whatever, for healthcare questions. I mean, 16% today, that's probably going to be 50% in the next couple of years. So like, how do we provide guidance to the patients, support the patients with better tooling and better mechanisms to get like more accurate information? Because to your point with your story, you're telling me that pretty much everything that you learned was kind of wrong. And so is there a way to help the patients better prompt these systems, or are there actual like tools? Is there going to be like an open evidence that's specifically for patient care? Right now, it's like the viral application that every doctor wants to use and trust. Sorry, Deepti and Howard, you may want to cover your ears, but they are using it. And so like, what is the patient facing version of that? And then on top of all of that, what are the things that we can do to help with the rocks that the patients have in their shoes, trying to navigate the complexity of our system, which is so hard to navigate across? That's actually a lot of what we're doing at Cadence, is sort of like, how do you like help the patient in between care remotely across like their journey across their, because they struggle so much with social determinants issues, with transportation issues to get to their visits, to like with understanding their medication regimens. 40% of the time when we talk to patients and we ask them about how they're taking their meds, 40% of the time they're not taking their meds the way that they're listed in their EMR, right? And a lot of it is related to behavior. It's not understanding, not wanting to take it because they don't understand how it benefits, not knowing, not liking the way. And it's all these things that we don't know as doctors that's kind of happening behind the scenes after the patient leaves the office and goes home. And so how do we help the patients? How do we help the patients follow what the doctor ordered, follow the advice that we're trying to give them, and reinforce that plan of care so that they stay adherent to that plan?
Yeah.
I think
I'll tell you that I don't think any doctor is expecting AI to replace clinical reasoning at any time soon. We are craving for AI to replace all that noise that's in the system today. And I use this term cognitive scaffolding, which is basically what I want AI to do. Which is take away the administrative tasks, take away the revenue cycle, mandatory stuff that I need to do, or the regulatory stuff that I'm obligated to do, care coordination, synthesis of information, medication education, all of that, monitoring of medications even, and monitoring not within the health system, but even outside the health system. All of that needs to be driven by AI so that I can actually then synthesize the information meaningfully for clinical decision making. A lot of agentic AI can be developed for all these other cognitive scaffolding things.
So, Deepti, I think we can take it one step farther. I think we are at a time in the very near future where all of that synthesis of information, as appropriate to what your specialty is, to what data the patient provides, to what data is available in your system and outside, and putting all of that together in a way so you can make the right decision easily. We shouldn't be collecting all that data in the charts. It should intelligently go find that and deliver it.
Yes.
So we can have that experience.
Yes.
Right. Absolutely. 100%. That's why I started with intelligent systems. That's what we need EHRs to become.
Yes.
Love it. All right. Our last question, we have a peer challenge. Evie, I want you to lead the challenge for the group. I want you to ask Howard and Deepti one question you think that every health system needs to face as we look at next generation EHR.
Yeah. So whether it's within the EHR, whether it's with a third party, prioritizing and implementing it is a very long runway. And as we look at how fast everything is moving, what would it take? What are some things that could happen if you could reimagine this whole process? What are the things that could happen to be able to move more quickly? Is it a resourcing issue? Is it a decision-making process that could move more quickly if you had X, Y, and Z? Is it the evaluation process? What are things that could move your ability to bring things in at 2 to 3x the pace that you're able to do it today?
Great question.
I would say prioritization. Actually looking at what your health system needs and agreeing to that in a rapid fashion. Because I think we can turn around and find the technology. We can identify the people and processes that need to support it and implement it. But so often leadership can't agree on exactly what is the highest priority because everything is important. And when you have that situation, you're doing partial work in all those different areas and you're not delivering the results that we could.
Yeah, I'll take a little bit of a different stance, which is we spend too much time optimizing legacy workflows. We are always constantly working to tweaking workflows that have worked for us. And this ties to culture of the organization. We should just become people embracing modern technology and redesigning workflows constantly to adapt modern technology rather than optimizing existing workflows. I think there's a lot of waste in the system because of optimizing existing legacy workflows.
Those are two really good answers. The decision-making process of prioritizing from the top down and bottoms up, and then the ability to really start thinking about the fact that we may need to replumb components of how we do the work. Love it. It's good stuff.
All right, as we wrap up today, I want each of you guys kind of in a rapid fire. You got 30 seconds to share some key takeaways for other informatics leaders in the country. Deepti, why don't you go first? What would you like to leave people with today that they should be thinking about moving forward?
Well, I'll say, we have reached a point where 10 years ago, technology was the barrier. We have reached a point where technology is no longer the barrier. The next generation EHR is not about software. It is about restoring clinical cognition. And whatever we can do to restore clinical cognition, that'll be a successful EHR.
Howard, what about you? What would you like to leave people with?
I agree. I think really it's looking at where we are today and saying, for 20 years, we've been trying to get people to use the technology. Now they're taking and running with it. And I think there's a real risk. I disagree a little with Deepti. I have my CISO on speed dial and they have me on speed dial. So every time someone says, I found a new AI I'm going to go use, we wind up in a conversation. But I think really it's education around people, how to use these tools and really get them to use them effectively. We've thrown so much technology at people and they're using little pieces of it. We need to get them using it correctly. I think a lot of that training and support is going to be a big part of what we need to do in the near future.
Oh, thank you, Howard. Evie, how about you?
Well, I'm hopeful. I'm listening to two CMIOs from big health systems, and I think you guys get it and you understand the landscape and what the opportunities are, and there really is opportunity. So despite all of the concerns, I get the security issues, all the governance, all the prioritization that you all have to deal with. I do think that it's an exciting time in that there's finally some hope. There's finally some hope of some of these solutions that are really starting to improve the way we practice. And it's going to be messy along the way. But I really do feel like we're entering a next frontier of hopefully restoring joy in practice of medicine.
That was really well put, Evie. Well, I want to thank Howard, Evie, and Deepti for a clear and I think very practical conversation. I'd like to thank you for joining us on Beyond the Blueprint. I'm Greg Malcry, and we look forward to seeing you next time. Thank you for listening to Beyond the Blueprint. Together, we're exploring how thoughtful design can simplify complexity, enhance patient care, and create meaningful change. If you found value in today's episode, make sure to subscribe and leave a review in order to help us continue the conversation. Let's reimagine healthcare together on Beyond the Blueprint.